Thanks for joining us. I thought firstly I'd just cover a few things about COVID in general. So as you all know, COVID binds to the angiotensin converting enzyme ACE2 receptor on host cells. And the four different steps here are the different ways in which this organism can cause damage in human hosts. Firstly, is a direct cytotoxic effect on cells. Secondly, because the ACE2 receptor is part of the renin-angiotensin-aldosterone pathway, it leads to tissue damage, inflammation, and vascular permeability. When this occurs in endothelial cells, that's when there's issues with thrombus formation and activation of inflammatory cytokines. And largely, step 4 here with the dysregulated immune response leading to cytokine release syndrome is the main step that the current therapies aim to target in order to reduce the end organ damage that's the result of this infection. As you all know, there are a number of risk factors that predispose COVID, but these ones have been associated with severe forms. And obviously, it's important for us being at Peter Mac, given that malignancy and immunocompromised patients are at high risk of these types of infections. Just a bit on COVID in cancer patients. It's said that the COVID-related mortality is up to 25% and can be as high as 60% in patients who end up requiring an intensive care admission. There's said to also be at least a 4-fold increased risk of death in hematology patients and about a 2-fold increased risk of death in oncology patients. There's also this phenomenon of prolonged viral shedding that's been observed, particularly in immunocompromised patients, sometimes up to a month after an acute infection, but has been recorded up to almost 3 months post-infection. And most guidelines actually recommend follow-up testing of this status, not so much because there's a strong correlate with ongoing infectivity implications of this and potential environmental contamination from fomites. And as you'll see in the course of this talk, the cancer cohort are often excluded from a lot of the seminal studies on COVID, which makes it quite difficult to extrapolate data to our select population. And this is a little bit of a busy slide, but I've tried to condense sort of some guidelines from America and also Europe about whether treatment should be postponed or interrupted and when to resume, particular to cancer patients. So in general, treatment's recommended to be postponed or interrupted if patients test positive and postponed until recovery. The definition for recovery is actually quite loose, but most guidelines refer to resolution of symptoms and fever for at least 24 hours and also a negative PCR test prior to resuming the therapy. On a case-by-case basis, some therapies such as Bruton tyrosine kinase inhibitors, some hormonal therapies, and drugs targeting activating mutations such as the vascular endothelial growth factor inhibitors can be continued on a case-by-case basis. That's because there are some very small studies that might suggest some benefit in patients with cancer and COVID, and also some that demonstrate a neutral effect. And in terms of recommendations for restarting systemic cancer therapy, in general, it's recommended that this should be delayed by at least 10 days from the time of symptom onset or from the first positive test, but can be extended out to at least 20 days for immunocompromised patients. This second dot point is mainly from the CDC guidelines, and they actually specify the definition of what an immunocompromised patient might be, which I've reproduced here. The American hematology guidelines and the transplant societies have put out some statements about delaying transplant or cellular therapies. This is generally anywhere from 14 to 21 days from symptom onset or date of first positive test. And I guess the reason for this is probably because the therapy themselves can be immunosuppressive and they're used in immunocompromised patients. There's not much data on surgery itself. This, however, was a guidance produced by an Australian surgical journal. They don't actually define what minor surgery or major surgery means, but the assumption is that the pulmonary status improves within the month after an acute infection, and so it's thought to be safe to proceed to minor surgeries, potentially ones that don't require intubation within 4 weeks of testing positive and recovering, and major surgery, the recommendation is to delay this by 8 to 12 weeks. So that's all I had for a bit of an overview for COVID in cancer patients. I'll just pass on to Ben to talk about vaccinations. Thanks, Ben. I'll just stop sharing my screen.
Yep. So I think, let me know if you can see my screen now.
It's just not on presenter view, Ben.
Okay.
That's right.
Better?
Right. Yeah.
Oh, sorry. I skipped ahead in my head.
Thank you.
So look, just to, as Joe has kindly highlighted that unfortunately patients, immune compromised patients, but certainly patients with cancer were excluded from all the pivotal clinical trials of vaccination last year. But certainly there's a lot of studies now out looking at, prospective, retrospective studies out that look at immune responses in various underlying disease groups. But of course, these are immune responses and are not equivalent to clinical efficacy as well. And the other thing to remember, in terms of looking at the results of these studies, is that they're actually just touching on often just seropositivity, so not seroconversion or seroprotection, which are often much higher thresholds. Higher antibody thresholds. So just for the next few slides, I've just summarized the rate seen with various disease groups. For example, with CLL, it often has the lowest humoral response of all the groups, not surprisingly, because of underlying disease, but also the type of treatments they receive. So about 40-50% overall, lower when someone's on a BTK inhibitor, and even lower if they're receiving something like venetoclax and CD20 antibody therapy. With myeloma patients, it's actually not too bad. It's around 60-80%. Some much better if you're on, for example, just LEN maintenance. And then again, it seems that the trend is that with monoclonal antibody therapy like daratumumab, which is an anti-CD38 monoclonal antibody, it's lower than the cohort. With cellular therapies, it's actually not too bad, 70-75% for allo and autologous transplant. But in these studies, they were vaccinated much later, so at least around 9 months post their stem cell infusion, and about 60% in CAR T cell, again, depending on timing of their vaccination. Other disease groups overall much better. So myeloproliferative neoplasms and such as essential thrombocytopenia do very well. Acute leukemia post completion of leukemia therapy also do really well. And the heme overall is about 67%. We have just completed a meta-analysis, and hopefully it'll be out soon, that shows that it's around 67% overall when we summarize humoral responses. But I think what's important not to forget is that there's actually on the background, which we don't measure very well, and a lot of these studies don't report it, are cellular responses, which I think play obviously a complementary role in protecting people against COVID-19, but is one underreported and undermeasured. Solid tumors, I think we can be reassured that they do incredibly well, almost close to a normal population, if you like. So close to 95 to 99% will respond to the vaccine. And in the reference below, the latest sort of references from Oosting et al. Presented recently at ESMO, what was interesting is that they compared 4 cohorts, basically a normal cohort, a group on chemotherapy, a group on immunotherapy, and a group on chemoimmunotherapy, and all basically have responses between 95 to 99%. So that's incredibly reassuring. And the other thing to highlight is that so far, there are no real differences by vaccine types, although there's some suggestion that perhaps Moderna do a little bit better. And then there's also no higher expected adverse events rate or immune related adverse events rates with checkpoint inhibitor therapy. So common questions that we're getting nowadays is third dose, and most of the data that third dose data actually come from solid organ transplant patients that show that perhaps that with a third dose that you get between 30 to 37% improved level of serological, so 30 to 37% of of people who didn't respond after the third dose, and also high levels of SARS-CoV specific T cells. With now emerging data with third dose in heme malignancy, not peer reviewed yet, but again, tends to show more that with the third dose in our patient group, that they will increase, those who have already responded will further increase their antibody levels. But unfortunately, those who have not responded to the first two doses don't seem to then further improve the antibody response. However, like I said, undermeasured and underreported, but I would suggest that certainly cellular responses do improve with third doses. And then looking at mixing third doses, again, this was a non-peer review study in preprint for CD20 treated patients, which included more in autoimmune disorders, that they just looked at the third dose being an adenovirus versus the same mRNA as the third dose after first two doses of mRNA, and perhaps not significantly different serological responses, but also an improvement in T cell responses following this third dose. So I will skip through these few slides quickly, but these are the things that have already been put out there in terms of the state guidelines about practical aspects of COVID vaccination in our patient group, and they're also our PETAMAC sort of, if you like, guidance documents. So just general considerations, talking a little bit about adverse events, timing, nothing dramatic, but just saying don't interrupt cancer treatment, and where possible, unless someone is profoundly neutropenic, you can still proceed with vaccination. And I think I might skip these because they're all publicly available, and then might touch on a few scenarios that I think would be good to get input. But so I've sort of, to summarize some of the common scenarios that we've been asked. So I think in someone who's currently unvaccinated, I think it's more straightforward that we now recommend 3 doses. And for Pfizer, and I think it's a lot easier now to just complete it with mRNA vaccines, just again, purely from a practical perspective, and not because, we think that there's anything wrong with AstraZeneca. I think for Pfizer, their dosing intervals would be, first dose, then second dose 3 weeks later, and then basically a third dose between 2 to 6 months after that. And the same with Moderna, except that the Moderna interval is 4 weeks between the first 2 doses. But for patients who have completed already their 2 doses, then they should have gone to have their third dose, again, 2 to 6 months after the second dose. ATAGI have recommended mRNA in preference to AstraZeneca, and this is because there's just more data out there for the use of mRNA vaccines as third doses compared to AstraZeneca. And they have suggested that ideally, if people have had mRNA vaccines before, that you should try to keep it the same. But the common scenario that I've been asked in the last week and a bit is that if people have had 2 AstraZenecas first, then what do we do with the third dose? Certainly, from my reading of the ATAGI suggestion is that, and also the same in the UK guidelines, is that an mRNA vaccine is recommended as the third dose. But in Australia, it also says that third dose of AstraZeneca is also acceptable if someone has not had any problems with it. So it's not a contraindication to the use of AstraZeneca as third dose, but I think my reading of it is that if there's a choice, then use mRNA as a third dose. I think the next scenario is a little bit more tricky. So if someone's already had 1 dose, and then they go, oh, what do we do next? Is it 2 mRNAs next? Is it like, if I've had AstraZeneca, do I then switch to mRNA for the next 2 doses? I think it's unclear. So I'm happy to sort of discuss that further with the group about what we as a group would be happy as consensus, especially with someone who's had AstraZeneca first. I'm sort of more in favor of trying to keep the first 2 doses the same and then switching to mRNA, but it's not particularly evidence-based there. And then I think, the other scenarios to think about is that if someone's not vaccinated and had a COVID-19 infection, I think, at the moment, I think 2 doses should be enough. And this is where I think the timing of of their vaccination after infection is a little bit unclear. So certainly ATAGI and also the state guidelines just says, look, it can be given anytime following clinical recovery, but if needed to be, can be deferred up to 6 months. Where the CDC is slightly different is that they talk about waiting for 3 months if someone's been treated with a monoclonal antibody therapy, including Regeneron or sotrovimab. But ATAGI and the state guidelines don't make any distinction or mention of this at all. So again, so when do we time the start of their vaccination in someone not vaccinated and then had COVID? I think again the same sort of scenario, except that if someone has had a single dose and then a COVID-19 infection, do they then go on to have 2 further doses, 1 further dose? I don't think it's as clear. I think at minimum you would want them to complete their second dose. And just to finish off, I think the final scenario is people who have had stem cell transplant or cellular therapy, that we recommend revaccination regardless of however many prior doses they've had. So consider it as a reset. And so then to give 3 doses starting at about 3 to 6 months post their transplant or post their infusion. And then of course, then the schedule is as per someone who's unvaccinated, depending on which vaccine they're going with. Oh, and sorry, just to end that, we do not recommend serological testing because I think this audience already knows, but because of the multitude of assays, platforms, and there's no established threshold that correlates with clinical efficacy or protection. And also just because on serology someone's negative does not mean that cellular responses are not protective, nor present. So happy to talk through the different scenarios. I'll bring it up again. Comments or questions? Or do you want to do scenarios at the end? Whatever we prefer.
Oh, Ben, hi, it's Monica here. I've just got one question, and that was 1 dose of vaccination, then COVID infection. Mm-hmm. What's generally recommended there?
So nothing set in stone. So no guidelines actually say, tell us what to do really in that instance. If someone has, whether someone then just needs 1 further dose, after they've recovered from COVID, or that they should have, 2 doses after they've had COVID. So yeah. So not clear in terms of how many they need after that infection. It's certainly not clear in terms of what the best timing is. So I think overall, it would be similar to those who are unvaccinated and then got COVID. When would we time their next vaccine? Is it as soon as they recover, or is, as CDC suggests, wait 3 months just because you want, I guess, the pre-existing monoclonal antibody therapy, if they've received a monoclonal antibody, to wear off, and then you boost it with the vaccine. Yeah.
Thanks, Ben. In the interest of time, we might keep going and then we can come back to a broader discussion.
Sure.
Okay, Joel, am I the next one?
Yep, you're next, Julian.
Good. Can you see my slide now?
Yes.
That's good. So hi, everyone. Thanks for giving me the chance to talk about the evidence available behind the recent approval by TGA of this monoclonal antibody called sotrovimab for the early treatment sorry, of COVID-19 in high-risk patients. So as you probably know, sotrovimab has other neutralizing antibodies targeting COVID-19 aim at blocking the viral infection by binding to the spike protein and preventing it from interacting with the ACE2 receptor, which is present on human cells. This is what vaccine-induced antibodies usually do in vaccinated people, but not everybody is vaccinated, and not all vaccinated patients produce antibodies after vaccination, just as Ben showed. So the Australian TGA has a pathway called the provisional pathway for speeding up the registration of promising new treatments for COVID-19, and under these pathways, this pathway, new drugs can be evaluated rapidly, taking into account several factors, including the seriousness of the COVID-19 pandemics, of course. And here is a list that is on the TGA website of all the drugs which have been or which are currently being evaluated using this pathway. And you can see that only 2 drugs have been approved under this pathway so far: remdesivir in July 2020, and the monoclonal antibody that I'm going to talk about today, sotrovimab, which was approved just a few weeks ago. So it's important to understand that these approvals depends not only on the available evidence, but also vary between countries depending on sponsor submissions, of course, local situation and other parameters. And as a consequence, what is available in Australia might and is not what is available in America or in Europe, for instance. And as we'll discuss at the end of my presentation, things are also moving very rapidly, and it's likely that other monoclonal antibodies will be approved in the next month to prevent or to treat COVID-19. So today's talk is about sotrovimab, and we now have recommendations made by the National COVID-19 Clinical Evidence Task Force, saying that we can consider using sotrovimab for the treatment of COVID-19 within 5 days of symptom onset in adults who are well and who have at least one risk factor for disease progression to severity. And as you can see, the list is relatively long. Patients who have diabetes requiring medication, obese patients, patients with an eGFR below 60, patients with heart failure, with COPD, with asthma, or even patients that are simply over 55 years of age are considered high-risk patients for COVID-19. And we can consider using sotrovimab in these patients. And obviously, they recommend against using monoclonal antibodies in fully vaccinated patients. An exception to that is obviously immunocompromised patients who, as Ben said, might not respond well to COVID-19 vaccines. So on a very practical point of view, you probably received this email sent by Cass a few days ago explaining that it's available. Sotrovimab is now being dispensed by the Alfred with the possibility to access it to in several sites listed here, including the RMH. So the goal of my presentation now is to summarize the evidence behind this approval by TGA of sotrovimab. If you search for a randomized trial on sotrovimab in PubMed, you will not find anything. The only clinical evidence that is available comes from this randomized trial called the COMET-ICE trial, which has not been peer-reviewed and has only been published as a preprint in May 2021. And we also have additional evidence related to this trial in the TGA report, which was published in August 2021 and included some updated trial data for the participants. So the COMET-ICE trial is an ongoing multicenter double-blind randomized control trial performed in more than 50 sites, mainly in the US. It's of course funded by the pharmaceutical company producing sotrovimab, which is Vir Biotechnology in collaboration with GSK. The trial participants were adult patients only who had early and mild COVID-19, defined as having symptoms for less than no more than 5 days, and not requiring oxygen therapy. All included patients were considered at risk for progression of COVID-19 using the factors that I just listed a few slides ago. Important to understand that they systematically exclude vaccinated patients, hospitalized patients, as well as severely immunocompromised patients, including cancer patients. So that's, I think, an important information for us. And they compared a single infusion of 500 milligrams of sotrovimab with a placebo, and the primary endpoint was either hospitalization or death by day 29 post-infusion. So it's a bit complicated because this is an ongoing clinical trial, but as you can see on the left side of my slide, the goal was initially to include 1,300 participants in total, but after first interim analysis done on using data on around 600 patients available in March 2021, it was decided to cease the trial due to probable efficacy. And while the COMET-ICE trial only includes data for these 600 patients, TGA had access to updated data, as I said earlier, for more than 1,000 trial participants, all followed until day 29 at least. So the trial participants, according to the TGA report, what we know is that they were relatively young, a median age of 53 years. They had only around 10% of the participants who were over 70 years of age. And the most common risk factor, probably related to the fact that it was done in the US mainly, the most common risk factor for progression of COVID-19 was obesity, present in around almost 2/3 of the trial participants, followed by age over 55 years, diabetes and asthma. And almost half of the patients had at least 2 risk factors, for instance, obesity and advanced age. So I won't talk about the safety profile of sotrovimab, which seems excellent, even if, of course, severe side effects can always occur and have been described, not in this trial, but with other monoclonal antibodies targeting COVID-19, including anaphylaxis. So these are the results for the effectiveness of sotrovimab. These are the results provided to TGA for the on the left side for the 1,057 participants. As you can see, the risk of hospital admission or death by day 29 was significantly decreased from 6% in the placebo group to 1% in the sotrovimab group. Well, this is really great news. I think it's important to understand that this was largely driven by hospital admissions and not at all by death, with, as you can see, only 2 deaths in the placebo group, which included more than 500 participants, as compared with no death in the sotrovimab group. So the number needed to treat to prevent 1 hospital admission in this patient population was around 20. And if you look at the participants who were followed until day 29, looking at the patients who required hospital admission, you can see here that very, very, very few required mechanical ventilation. So none in the sotrovimab group and less than 1% in the placebo group. So again, we are unable to assess whether sotrovimab made a difference on this outcome, as it was the case for death. So I guess the next question at this stage is, can these trial results be applied to our population of Australian cancer patients? So that's the question of external validity. So I guess the main point is that we don't have data in cancer patients. Cancer patients were systematically excluded from the COMET-ICE trial. And if you search for cancer and sotrovimab on PubMed, again, you don't find anything. So while the benefits of sotrovimab may potentially be higher in cancer patients and other severely immunocompromised patients, because these patients have a much higher risk of death than the patients included in the COMET-ICE trial, this remains largely unproven. And it's also very unlikely that we'll have randomized controlled trials specifically focusing on cancer patients. So the second question is whether sotrovimab remains active against the Delta variant that is present in Australia. While none of the participants included in the COMET-ICE trial had proven Delta variant infection, GSK states that sotrovimab remains active against the current variants of concern, including Delta. But this is based on their own in vitro data, and it'd be great to have in vitro and possibly clinical data published on this very important point. And last, a third question is whether our, especially our cancer patients and other patients may develop mutations following sotrovimab infusion and have immune escape. So I'm not talking about mutations present at baseline, as it's the case with variants, but I'm talking about mutations emerging on sotrovimab. What the company report is that some patients in the COMET-ICE trial had sequencing data showing emergence of mutations on sotrovimab. And we know that some of these mutations may theoretically be associated with reduced activity or even with treatment failure and rebound of viral infection. And this, of course, needs to be monitored clinically, especially given the growing evidence showing that patients receiving bamlanivimab, which is another monoclonal antibody for COVID-19, may have emergence of treatment-related mutations and eventually treatment failure. The good thing is that sotrovimab seems to be way more robust than bamlanivimab, but however, some mutations have been found to confer reduced in vitro susceptibility to sotrovimab. And that's definitely something that we need to keep in mind when treating heavily immunocompromised patients, especially starting with very high viral load at baseline. And the last thing is that it's a rapidly evolving field. I only spoke today about sotrovimab for early treatment of patients with COVID-19. But there are many different monoclonal antibodies, as you know, being studied for the prevention and or for treatment of COVID-19. And as I showed earlier, the Australian TGA is now evaluating both the Regeneron cocktail of antibodies and the Celltrion antibody. And the product conceived by Regeneron and distributed by Roche, which is called Ronapriv, has a good chance to be approved given the 2 trials published in the New England Journal of Medicine in the last 2 weeks as post-exposure prophylaxis and then as early treatment. But also given the unpublished recovery trial, which showed significant mortality benefit in seronegative hospitalized patients with an impressive decrease in mortality from 30 to 24%. So so the needs might be relatively important, and I guess especially if a significant part of the population remains unvaccinated in Australia, if the daily numbers of cases remain high, and if we start using monoclonal antibodies outside of the current indication of sotrovimab, which is early treatment of mild COVID-19, we might need quite a lot of monoclonal antibodies in Australia. That's the end of my presentation. Thank you very much. Is there any question about sotrovimab and this trial?
Thanks, Julian.
Julian, a quick question, Monica here. The seronegative issue is interesting, using that potentially to guide use of monoclonal antibodies in patients being admitted who are seronegative, presumably early or unable to mount an immune response. Did you find much about that approach? Was that discussed in the papers that you looked at?
So in the COMET-ICE trial, all the patients by definitions were seronegative because they systematically excluded vaccinated patients. The question, I guess, is more for hospitalized patients that are admitted with COVID-19. especially given the recovery trial showing, a major mortality benefit in these patients, but only if the patients are seronegative at time of admission. I know that Ben said that we should not, test for the presence of antibodies, but if it becomes something that is needed to, to assess whether the patient might benefit from monoclonal antibodies, I guess this might change in the future. I don't know if Ben or anyone else or someone from the lab in particular may have a comment about that.
Yeah, Julian, I don't think it's just testing. If someone's seronegative, sure, I think you at least have a stronger sort of basis to guide, monoclonal antibody therapy. But I guess, if you do it and if someone is barely seropositive, would you then say they don't need monoclonal antibody? I mean, I'm just turning it around. So I think in immunocompromised patients, look, I think it might be the case for general patients, but I think in immune-compromised patients, I think it would be challenging to use that until you establish a particular threshold. I think it's challenging to say, at a certain thing, we would do it or we won't do it, because I don't think you can exclude people who are just purely seropositive, not seroprotected, but seropositive from accessing, unless you've designed a specific trial, obviously, to do that.
But maybe there would be data from recovery on immunocompromised patients that were seropositive as well, because they included thousands and thousands of patients. I think 2,000 or 3,000 were seronegative, and more than that were seropositive in the randomized trial. So yeah, and I guess some of these patients, because this was a relatively pragmatic trial, so quite a large part of the a significant proportion of the patients may be immunocompromised patients, and maybe we'll have data on that. I don't know.
Yeah. So and Julian, I think in your last slide you summarized, I think, one of them from I think Astra, that basically, yeah, the other ones, I think the Prevent or Provent trial is what they've released, what they've issued press releases about how it's effective in pre-exposure prophylaxis. Yeah. So
sorry, I missed that. Too many papers, too many
I know.
press releases,
just,
too many.
Just something I remember. I think it's called Provent or Prevent. I can't remember.
Yeah. And is our colleagues from the lab online?
Hi, Julian. Sorry, I just had to take a few phone calls during the presentation, so I'm a little bit out of it. Look, I think it's difficult though, as Ben said, we've got no correlate of protection from an antibody level. People are certainly doing work on that. I know the human challenge trial stuff will be working on that, which will probably give us the best evidence, but that's still probably, 6 to 12 months away from getting a proper data set that's going to be published. There's in our lab, from a practical perspective, we do have 2 different assays that are run, on reasonable throughput machines that are available Monday to Friday. We do runs every day, and we do an S target and an N target. So, we can give an idea about whether it's going to be vaccination versus natural infection. But yes, there are those difficulties, and obviously it's not the gold standard neutralization assay, which we still send all our RMH samples off to Vigil for testing on that, and that takes weeks to come back. The surrogate neutralization testing is done a couple of times a week, or 2 to 3 times a week at Vigil, but it's not something you could necessarily have your patient arrive in ED or get your positive test result, get a serology taken, and a final result acted on accordingly very quickly. And obviously time matters with sotrovimab, right? So I think there are practical difficulties, and
it will be a practical challenge if these drugs are approved for hospitalized patients.
Yeah, absolutely. And look, I think that's a broader issue. Listening to the vids unit meetings and stuff about sotrovimab, it's not about access to the drug anymore. It's about how do we deliver this to the people that need it at the time that they need it, which I think needs probably a statewide solution that's not particularly forthcoming, just because of the difficulties with the side effects and risk management surrounding positive patients in
especially given that these patients are very contagious.
Exactly. Yeah, they've got high viral loads at that time of their infection, and there are some rare side effects of anaphylaxis, etc. How do you manage that safely in an out of hospital site? Like, there were a lot of good plans, I think, put together by the RMH Hospital and the Home Services to deliver this as an outpatient, but there's been some, I think, higher level pushback about the safety aspects of that, even though there could be processes potentially put in place. So yeah, I hope we get there. I hope, and I think there's people working on it at a level, mass administration level, that hopefully we'll get there.
And Eloise, sorry, I just wanted to just go back to what you were saying about serology testing. Is there at the moment stewardship of who gets those tests, especially if someone's just asking for measurement of vaccine responses?
Yeah, absolutely. They come through us, yeah.
Against, but yet we know that some people have been getting it and then creating quite a difficult situation for both the patient as well as their clinicians.
Yes, no, totally. They should all come through us before they're tested, through Catherine or I or another microbiologist before they're tested. Obviously, sometimes things fall through the cracks, but that should be rare that happens. So yeah, they should have that discussion with the clinicians prior as to the indication for the test.
Thank you.
And to be honest, mostly we're doing it like for clearance. So there's a lot of, as you can imagine, pressure on beds on this side of the bridge. And the department did or still does have a, for the kind of complex patients, ICU, etc., immunocompromised, etc., who are still sick in ICU after 21 days, there is a bit of wiggle room to use both like their CT values, clinical progress, and serology results in determination of whether they can be cleared from an infection control point of view, so that they can be de-escalated and moved on to a non-COVID ward, and obviously still be managed in hospital. But obviously there's a lot of bread pressure for those COVID wards, and particularly in ICU, etc.
Thanks, Eloise, and thanks, Julian. We might move back to Joe. You've got some more slides, haven't you, Joe?
Yeah, I do. I may not be able to get through all of them in the interest of time, but we'll see how we go with some of them.
Sorry, Joe, we took some of your time. Sorry about that.
Oh, no, that's okay. I enjoyed listening to both of your talks. So I'll just share my screen again. So these two tables are put together from the National COVID Clinical Evidence Task Force, and what I wanted to emphasize was that there are some agents that are recommended, obviously sotrovimab, which Julian talked about, as well as other monoclonal antibodies or direct-acting antivirals. But there are also some repurposed drugs that have some evidence base to them, and so are recommended for use in select COVID patients. There are a number of agents that are under review as well, where published studies have demonstrated maybe some effect. Conversely, there are also agents that are strongly not recommended, which I've listed at the top, and also a vast range of different agents from different classes that are restricted to use in clinical trials that are still being evaluated on an ongoing basis. Moving to a more global perspective, but the WHO does endorse similar agents to our local COVID task force in that systemic corticosteroids and IL-6 receptor antagonists are strongly recommended, with a conditional recommendation simply because the evidence base is still building for the direct antivirals in the middle. And there's actually quite strong recommendations against use of hydroxychloroquine, lopinavir, ritonavir, and ivermectin. Right, so if I've got time, I'll try and present dexamethasone and IL-6 receptor antagonists. So this study was published out of the recovery group on dexamethasone and mirrors what's in the Australian COVID treatment guidelines. And it's the exact same dose that's recommended that was used in the study that's in our guidelines. And I should stress that it's reserved for patients who are receiving oxygen and also those who are mechanically ventilated in ICU. So this was a very large trial, mainly out of the UK through the NHS, and initially included just adults, but this criteria was removed after the initial COVID surge in the UK. The intervention was usual care, which at that stage did not include steroids, but later moved on to usual care with IV dexamethasone. The outcomes, mainly the primary one, was 28-day mortality with a variety of secondary outcomes as well. When looking across subgroups, the two groups that I wanted to emphasise were that patients aged under the age of 70 tended to benefit the most, as well as those who had more prolonged course of illness, so greater than 7 days of symptom onset. But as you can see, most of the subgroups here tended to fare better when they received dexamethasone. And also the main outcome was clinical benefit in the two cohorts that I've described, so patients receiving mechanical ventilation or oxygen. There was also significantly a lower mortality at 28 days in the dexamethasone group versus usual care, so 23% versus closer to 26% for the usual care group. Extrapolating this data, this is a meta-analysis that was conducted on 7 different randomized control trials that looked at different steroids, so dexamethasone, hydrocortisone, and also methylprednisolone at the doses listed here. And as you can see, it seems to be a class effect in terms of the corticosteroids themselves, which with an odds ratio of 0.66 on the fixed effect meta-analysis, demonstrating improvement in clinical outcomes with patients receiving corticosteroids who have COVID. Moving on to the IL-6 inhibitors, this is the REMAP-CAP trial that was published on inpatients who were in ICU. All of them had to be adults and had to have severe COVID requiring cardiorespiratory support. There were various different arms of this study that are still running at the moment, but the IL-6 inhibitors were tocilizumab and sarilumab that were compared against the control arm, and other arms contained different agents, which I've listed here. The primary outcome was number of cardiorespiratory support free days, and there were a variety of secondary outcomes that were investigated as well. The main outcome was improved survival in patients treated with IL-6 inhibitors, which you can see with the separation of the lines, these two being the IL-6 inhibitors compared to the control. Sorry, these two upper ones compared to the control in the red. There was also increased probability of discharge successfully from ICU in the panel on the left and discharge from hospital in the panel on the right when these agents were used compared to control. And also looking at the primary outcome, which was the organ support free days, the poor outcomes are highlighted in the red and the better outcomes or improved outcomes in the blue. As you can see, the IL-6 inhibitors were associated with lower number of days where there were poor outcomes with the patients. So a better result when they were treated with IL-6 inhibitors. One key thing that I noticed in the supplementary when I was looking through this data was that at this stage, corticosteroids were already standard of care, and so all patients or quite a number of patients in both the control and the IL-6 inhibitor arms received corticosteroids. There were also a proportion of patients who received remdesivir, and it's unclear whether this had any impact on the end results. They did comment on adverse effects attributed to tocilizumab. There are actually none attributed to sarilumab as such, but none were life-threatening. And just a new statement that's been put out by the TGA. It's unfortunate that although these agents demonstrate efficacy, there is actually a global shortage now of tocilizumab, and as a result of this, the TGA Medicine Availability Working Group has put out a statement recently that for patients who are receiving supplemental oxygen but who are not mechanically ventilated, perhaps an alternate agent, baricitinib, might be considered instead. So I'm not sure if I should go on because I have a few other agents that I've got slides for, but I'm happy to, depending on how the group feels. Otherwise, I might just skip to the outcome slides for each agent. So baricitinib is an oral selective Janus kinase inhibitor, and the interesting aspect to this agent was that it was identified through an AI platform as a potential treatment for COVID, explored and found to be beneficial. I'll skip through most of this, but just to point out that patients with cancer were excluded in this study. And the outcomes were a reduction in 28-day all-cause mortality for patients who received this agent compared to placebo, as well as reduction in mortality in patients on supplemental oxygen, and also those receiving high-flow or non-invasive ventilation. There was also out to 60 days a reduction in all-cause mortality as well. And what I wanted to point out was this very small subgroup of 5 patients who actually didn't receive corticosteroids. And I realised that the numbers are quite small, but it still produced an outcome that favoured use of baricitinib and better outcomes. And something to point out with this study, this was one of the rare occasions when the serious infections were actually specified. They were quite similar in both groups, despite use of baricitinib, and the different infections were listed here. So although there were some treatment emergent infections that occurred in both cohorts, these were relatively well managed and none led to an adverse outcome like death in these patients. This is the monoclonal antibody cocktail that Julian sort of touched on in his talk. Essentially, a preprint has now been published from the recovery trial that demonstrates that patients on this agent demonstrated reduction in 28-day mortality compared to usual care in those who were hospitalized with COVID. And this study from the New England Journal actually covers the outpatient aspect. And again, looking at the 2 different doses of Regen-CoV, both demonstrated reduction in hospitalization and 28-day mortality with a significant p-value in both cohorts compared to placebo. And the other outcome that was met was median time to resolution of symptoms, so 10 days as compared to 14 days with placebo. And remdesivir, I might skip over this in the interest of time, just simply to say that many trials, as well as the one that I had listed on the first slide, have demonstrated no clinical mortality benefit with remdesivir and also other agents that were co-investigated in these trials, which are the ones that are not recommended by our national task force and also by the WHO. And to finish, this oral agent, molnupiravir, is quite topical at the moment. It's similar to say it's an oral agent that can be used in the outpatient setting. It's got a different mechanism of action in that it targets the RNA-dependent RNA polymerase, so same target as remdesivir, but the difference is that this agent is actually able to escape the proofreading that the coronavirus usually does for this polymerase, and by doing so, actually stops the viral replication and hopefully demonstrates a high barrier to resistance. Just to skip over these bits, essentially people on this agent at the dose of 800 twice a day had a significant reduction in the RNA level based on the respiratory viral swabs, and also which you can see here by day 3, almost all patients who were taking molnupiravir at 800 milligrams twice a day had negative PCR results, and none of them had a positive result by day 5. This is compared to the lower dose of 400, where some patients were still positive, roughly about 10% by day 3, but by day 5, all of them had returned a negative PCR result. So potential effect in reducing viral shedding very early on in the illness. This drug was very well tolerated with not many side effects stated. Just 3 patients discontinued the drug. And it was interesting how in this study they actually undertook whole genome sequencing as well to look at the nucleotide changes in the target. And so they found that there were mutations in this target which led to the authors concluding that there was biological plausibility and demonstrable effect of this drug on COVID infections. I guess some criticisms are that this study was a preprint and so very small in sample size, and there were no specific clinical endpoints or comorbidities listed, but I'm hoping those questions might be answered by some follow-up studies that I've listed here. And just another thing to point out with interpreting the data, there was a slightly lower viral load at baseline for the group that demonstrated the greatest effect on reducing the viral load for SARS-CoV. So just bearing that in mind when we're looking through the data for this study. So sorry to rush through the end, but I've got some references which you can look through, and happy to take any questions, as I'm sure Julian and Ben are as well. Thanks, everyone.
Thanks, Jo, that was great.
So I'm not sure if Kaz is still here. We've probably met our time constraints, but just any questions for Jo before we finish up today? Okay, can't see any, Jo. Thanks for that really comprehensive run through, and thanks to Julian and Ben for giving us a really great overview today of where we're at with COVID prevention and treatment and what's coming down the track that we'll be dealing with soon. So thanks very much to all 3 of you for great updates today. And I'm sure this will be very helpful in our education sessions. And we might talk about that offline, how we're going to run those sessions to both haematology and radiation oncology next week. So thank you, everyone. Thanks for joining today. Bye.